Welcome everybody. Welcome to the March NENC Pain Community of Practice webinar. Our topic today is extended reality for pain management, XR for pain management. And for those of you who don't know me, my name is Dennis Martin. I'm Professor of Rehabilitation at Teesside University, and I'm Vice Chair of the XR for Rehab Consortium. The XR for Rehab Consortium is an international collaboration which has sprung from a series of EU-funded projects which have been looking at virtual reality, augmented reality, mixed reality, and increasingly AI for development and application in rehabilitation. The collaboration spans the Netherlands, Germany, France, Belgium, Ireland, and ourselves in the UK as the core, and actually has links all across the world. If you're interested in more, if you look us up, you'll see that we have a wonderful conference coming up in Cork in June, to which everyone would be welcome. As you'll see, XR for pain is something that has been about for surprisingly a long period of time. And its use in pain is one of the main areas of clinical development and application of XR in general. There's been a sharp uptick in research and clinical use and interest over the last 10 or so years. What I'm hoping you get from today is really a chance to get introduced to the idea, to get some insight into current research and practice, and get an idea of where it's going in the future, and take the opportunity to have a think and a reflection about implementing XR for pain management in your own practice. We have some housekeeping. Please keep your microphone muted and your camera off unless you're asked to speak. If you need to take a break, feel free to do so at any time. If you have any questions throughout the session, then please use the chat facility or raise your hand, and please don't interrupt. If you can't see the chat, please email Lola at the address. The event is being recorded and will be shared. We have two really good speakers for today. Both are colleagues of mine. Sam is a senior physio based in York, and he specializes in low back pain and MSK conditions. Sam's a member of the York and Humber CAPR and the PPA, the Physio Pain Association. He's working on his recently awarded NIHR pre-doctoral fellowship to develop up his work in looking at the potential value of XR as a way of improving accessibility to pain management for people in rural communities based on their geographical limitations and location. Our second speaker is Dr. Sil Slatman. Sil is a colleague of mine in XR for Rehab. He has a background in physio and health psychology, focusing on the use of XR and EF in physio with a particular interest in people living with persistent pain. Sil is part of the Innovation of Movement Care Research Group at the Han University of Applied Sciences in the Netherlands. And our speakers will follow one after each other. There will then be an opportunity for question and answer session. There'll be a short evaluation, and then we will finish and close, and we will do so on time. Now, there's some updates. The biggest update is that the community of practice is transferring from High NENC across to us at Teesside University and the local ARC. there is a transition arrangement being set up. All these details will be in the chat. The important thing is that to transfer across, we need you to give your active consent on the form, which is available on the link which you'll see in the text. So to continue to be part of the community of practice and receive the communications as you've been doing, if you could please click on that, fill in the form, and that will reconnect you with the community of practice. I would like you to take a short minute, please, to scan on the QR code and just complete a short survey. This is going to help us to evaluate the webinar and help us to continue and improve. We also have, as a side project, another series of webinars to follow on this about XR in practice and XR in implementation. When you sign up, we'll send the details of those other webinars, which are out with the community of practice, but I think you'll be interested in them. And that will link up, this survey will help inform that. So at 13:41, which is now, if we can go over to Sam as our first speaker. And Sam, if you want to take control. Thank you.
Brilliant. Thank you very much, Dennis. Appreciate it. So, as Dennis said, my name is Sam. I'm here to talk to you about XR in rural healthcare. A little bit about me to start with. So, I'm a physiotherapist. I work at York Hospital, where I am now doing my clinical academic fellowship funded by the NIHR. I'm doing it with TG University. And I'm interested in particular looking at extended reality in chronic lower back pain, looking at how that affects kind of rural populations, and can we improve service delivery in those populations. So yeah, okay. What is XR? That is a good place for us to start. There might be a little bit of duplication between what me and Sil do want to say, so forgive us for that. But ultimately, when I'm talking about extended reality, I'm talking about virtual reality, augmented reality, and mixed reality under an umbrella term. So that can get a little bit confusing, so I'll dig into those just in a little bit of detail. So virtual reality is where you're fully immersed in the system. So usually this is a case of you're wearing a headset, and the headset is showing you what your eyes would be seeing if you were in this environment. So it's normally delivered by this head-mounted display, computer-generated environment, and you're fully immersed. They're the key points. It can be used in a multitude of different settings. There's a lot of interest in the gaming sector, a lot of interest in education and training, and there's been, like Dennis was saying, in the last 10 years perhaps, big uptick in how people are using this for rehabilitation, physiotherapy, pain management, a lot of new interest in pain education as well. There are a little bit of conflating of terms here with VR. Sometimes it's been used to describe things like the Wii Fit board, or the where your avatar is represented in a virtual world. So that can, in research, sometimes be a little bit confusing, because you see when you actually look at the protocols that are used, it's not the immersive kind. So it is important to understand and recognize when we're looking at these that there's non-immersive VR as well as immersive VR. That then brings us on to looking at augmented reality. So the simplest and most common way this is used at the moment is really in the furniture world, being able to show you the products in your setting. So it's often where the digital information is overlaid into a real world environment. Excuse me. So you hold up your smartphone, your camera shows your living room, and then suddenly you can see that there's a sofa that you're looking at in your living room, and you kind of get an idea for it. We can use that in training as well. You can see in this image on the screen the surgical procedures. They've got an overlay there where they're able to look at what you wouldn't be able to see in depth, being able to recall information quite easily. And we can also use that in other training environments. It's really interesting when you start to implement augmented reality with physical objects as well, and that's where you get mixed reality, where we can use in our training programs physical objects where we interact with real life items in a virtual or digital environment. So you can see here we've got some training going on where there is a dummy, and what you can see in the top right hand corner is actually that is what the practitioner or clinician is seeing right now in their training. So it's a good way of simulating environments. We can use that in rehab as well. So you can think about introducing virtual objects into the environment. You can step over something in a room. You could create an assault course where you have to, dodge things. I've seen this used a little bit in the military where they are trying to replicate combat scenarios. It can be really quite versatile in how that is used. So that's what XR is. What I'm looking at is rural communities. So why am I looking particularly in rural communities? We have an awful lot of people that live in rural communities in the UK. There's a little bit of an argument about what rural is. There's been a little bit of research done in Australia where they have real rural communities where you need a flight to get to somebody to healthcare. But in the UK, we're talking about people who are a certain distance away from resources that it prevents them from engaging. So we call that distance decay. And I like to think of that where you don't have a gym on your way home. So you're less likely to go to the gym because it's an extra 15 minutes for you to get there. It's an extra 50 minutes to get back. It suddenly becomes a 2-hour activity. If you've got a gym in your garage at home, then you're much more likely to use it. It's about reducing these barriers. And that's why rural communities often have worse life expectancy in the UK than some urban areas. It's a little bit of conflating information as well because you tend to have an older demographic in rural locations. So perhaps they might need greater access to healthcare, but also there are hidden pockets of deprivation. We often think of rural communities as being larger houses, bigger houses, perhaps more wealth, but there are a lot of these areas of deprivation where the health outcomes are worse. And so trying to actually get these people to access healthcare, perhaps with a prevention point of view, is really important for improving the health of the community in the UK. So these are real problems that we're facing at the moment, and in particular, we can see in the areas that we're working, perhaps some of us in Tees, you can see the span of where we have the clinical commissioning group is working. We can see the areas of deprivation are in there. There's a lot around the coastal communities as well. So often transportation around those regions isn't as useful. Now, this isn't necessarily a good example of the rural nature here, because we can see actually in most of the rural communities, their deprivation is pretty good. But if we come into perhaps the Vale of York instead, we've got a bit of a wider span here where the hospital in Pickering is only very, very small. It'll be an hour drive to get to York, which would be their closest major hospital within their CCG, even though it would probably be easier to go somewhere closer that isn't under the same commissioning group. But when you're looking at trying to access these regions, we're on the border of North Yorkshire. Can we actually create better environments for people to access healthcare, even though they're still under technically our care in York, even though they're 70 miles away? And then we can see a similar idea in Cumbria where the coastal communities have greater deprivation. What we're trying to capture here is where you probably have the double whammy, where you've got low social infrastructure and areas of deprivation. There's very little going on to prevention of healthcare, and looking at digital solutions has been really effective with that. And using XR could help with that rehab being a lot more engaging and preventing. We know how important it is to get to conditions such as pain acutely, rather than letting them develop into chronic conditions. How can we then also combat chronic conditions at the same time? Well, we need repetitive input. How can we do that if the people aren't accessing healthcare? So, what do we know about XR in rural health? Well, we know it can reduce geographical barriers. That's just the nature of it being essentially telehealth in this setting. Okay, so I'm not going to talk too much about that because it's as simple as people don't need to travel to places. But there are questions around its clinical effectiveness. How do people suffer by not accessing healthcare face to face? And do we see that it does actually enhance engagement? What are the adherence level like? And what are the costs associated? Because this is a big thing that everybody always presents to me as saying, well, we can't just send everybody a headset and expect them to be able to engage with the latest VR program. That might not be the case when we look at breaking down the costs. So where has VR, XR, augmented reality, mixed reality been used? Early work, I was talking a little bit about those Wii Fit or Nintendo Wii platforms, looked at stroke, looking at motor recovery. So Piron in 2009 did some early work looking at what kind of movement home-based rehab devices exist. They found that actually having an avatar in a virtual world helped people engage really well and was much better at improving motor function, should I say, in upper limb and in balance. So that was people gamifying rehabilitation in a way, something that was then also seen in the Parkinson's group much more recently. This is the bit I find most interesting, is the higher patient motivation. So this compared directly with people having the same amount of time with a therapist, being given paper-based exercises, go home and do those, we'll check in with you in 6 weeks, versus try this device, use this at home, we'll see you in 6 weeks. The engagement levels were much higher in the XR group, and also they found it more enjoyable. So what's the best exercise? It's the one that you're going to do. It's a great example of how making something engaging and fun can be useful for that. We also see a similar outcome with total knee arthroplasty. Same principles of people engaged really well, but compared to people coming in to repeat 2 times a week, so 1 time a week, 2-month follow-ups, it was cheaper to have people actually be sent a headset and engage by themselves more frequently at home than it would be to actually have them come in repeatedly. That's only talking about systemic costs. It's not talking about actual looking at welfare, time saved, economic benefits by people not having to take time out of work to come and engage with healthcare. So there are wider system benefits that perhaps we could be looking at the same time. What about behavioral health? This is something that we don't necessarily look at enough. It's something that maybe we people here today are interested in pain management, but perhaps in wider society, it's not something that is talked about or engaged with enough. What about using it to reduce stress, helping us stop smoking, helping us manage phobias? All of these things are something that it's been shown to be effective at doing. I'll talk a little bit about that top one there, that chronic low back pain, in a moment. But if we think about the bottom line there, that social connection, again, this is something that is quite interesting. There was this Ava Park virtual park that was created, which allowed people to create an avatar in the VR world. So you put on a headset, you're surrounded by this park, green space, but it was multi-user. So you have other people who are in that space and you can essentially interact with them. It was shown to be much better for people with aphasia to start to begin to communicate with other like-minded people. It acted as a support group. It was better than the telephone calls that were run alongside because it reduced that flattened non-personable feel. So it's been shown to be really useful at kind of making things more real. I mean, I suppose the fact that it's called reality is probably in the name there, but it's been really effective at trying to help people engage more and get more out of their rehab. The adherence rates are pretty good in the trials that look at this, but they're not massive scales as well, so that's something to take into consideration. But smoking cessation, we're looking at what, a 4 to 5 times better outcome from people using these devices compared to not having any additional input. So these are just interesting other ways that we can use it. But here in chronic lower back pain, there's this Ease VR software. It's now called Relieve. It's been FDA approved. It's being used real time with patients in the US. I'm not affiliated with them in any way. I don't know where else it's being used, but there's a lot of information on their website about this. But this is really interesting system because they have pain education built in. So there's 53 sessions that they have recorded that you can engage with. They also have these other different aspects which we know help with managing chronic pain. So we have this mindfulness aspect to it. We have breathing programs in it. We have relaxation centers that you can go and literally go fishing in this game and you relax. So it is gamification in a way of rehab, but also with this immersive nature. So this is one of those programs that really could be used in a clinical setting. You can see kind of the cartoonish nature of the settings. So this helps with the kind of separating the reality. It can give you sensory overload sometimes in these environments if it's too realistic. And actually, so it's a choice to go for this cartoon effect. It also leads into the fact that the technology is only at a certain point right now. And that's worth recognizing because perhaps in 10 years' time, you might put on headsets and it's like you are in your living room and you can't tell the difference. We're not at that level at the moment, but now's the time to start looking into it because in 10 years' time, there's no point starting the process then, right? But we see that this mindfulness program is really effective. I'm going to just enlarge it slightly for you here. So you can see that that circle is looking at a dragonfly that in this environment is actually flying around. If you have the headset on and you're turning around and looking, you're looking at this world that is surrounding you. So we get the benefits of distraction because you're in a new world. You have the benefits of movement because you're following this dragonfly, you're moving around. It's also a very calm and relaxing environment at the same time. So often these headsets have built-in speakers and there might be bird sounds, a gentle breeze, classically relaxing environments to be in. So this is a really interesting program. It's not going to be right for absolutely everybody, but it could be a really nice place to start. And that brings me on to my next point. So we've got the system level savings. Talked a little bit about this already, so I won't dwell on it. But what we have seen in actual research in recent months is that it's been effective at reducing healthcare stays, hospital stays. We have this program where you use it before having surgery to help reduce your stress levels, which reduce the amount of time people were in hospital after the operation, reduce the pain post-surgery, and it was a wide-spanning variety of surgeries. The reference for this paper is at the end of these slides. It's definitely worth having a look at. But ultimately, it reduced the length of stay in a hospital. So a huge problem is getting people through the system, getting them through the acute hospital beds back into the community. They have a device that they can use for rehab and prehab at the same time. Reduce the length of hospital stay, save costs from there. The cost of a headset is less than the cost of a night in a hospital bed. So already you have some level of system level cost saving. Similar things seen in the rehab of knee replacements, like I mentioned already. And similarly to if you were running an exercise class, you can have multiple therapists working. So you can have a singular therapist working with multiple users. So we can help reduce burden from that sense. Reduce costs for patients traveling, reduce burden on community therapists. It has the potential to really save time and money. We see a little bit of the feasibility issues. I'm going to skip through this slide fairly quickly because essentially what we know is that adherence rates are quite good in these studies, but it doesn't necessarily show what a larger scale trial would demonstrate as to how feasible is it to implement these in on a system level. But we know that it has good scalability because it's digital technology, so the cost decreases the more that we use it, the more that we apply to participants, the more that they, or patients, should I say, the more the single unit cost comes down, just because we can use it more. They're fairly cheap devices, and the same as I mentioned before, multiple patients could use a device, or you could use a singular therapist to monitor multiple patients. So you can really scale that up quite easily. We see that there is good engagement, but there are barriers that we need to overcome with those settings. We've all tried to use Teams when it hasn't worked in the past. Like, everything's gone very smoothly today, so kudos on that front. But we know that people come into technical issues. So we've always got this question to ask around, well, what are the actual barriers to implementing this in these rural communities? What are the broadband requirements? What do these devices actually need to have video calls, to have download applications to headsets and things? Understanding what those actual barriers are not really fully formed with specific programs, because the heterogeneity across the research is huge. Nobody's using the same products, nobody's using the same system or the same interventions. So trying to understand, is this actually a problem in this day and age, or is this something that is quite easy to overcome if you know the problem exists? So things like coverage of broadband it covers 98% of the United Kingdom at the moment. Are the areas we're talking about in North Yorkshire and Cumbria, what are their internet levels like these days? Is this still a problem? Because it changes regularly and it does seem to be improving. Cost and device compatibility. Now, this is something that is a big problem, because when we're developing software, often you're feeding into either a Linux framework or a Unix framework or something else entirely. And if you're developing applications to be used with an iPhone, they're not going to automatically work on an Android phone. This has actually been a big barrier with research already as well, is it's much easier to develop software for Android users. And that has meant that a lot of people haven't been included in the research. So we need to get really to the bottom of that in a little bit more detail. That's also kind of ties in with the health literacy and the digital confidence. How many people have these smartphones? A lot of people do, for sure, but do the people that we're trying to access here have those devices? So that's something that I'm interested to hear people's thoughts around, and that's something that I'm going to be looking into in a little bit more depth over the coming years. And then there's this big question around the clinician perspective. So what is your role as a clinician when you're then shifting from this hands-on provider to a remote facilitator? Get quite a lot of people pushing back around this as a concept because it perhaps moves away from the traditional physiotherapy management approaches, but so did pain education when we first started to introduce that. So there's a question here around, how do people feel about this as a direction to be traveling, and what are the training needs around that? Do people need to build their digital confidence? Do they need to understand how they are rehabbing through these devices? What is the clinician's role within that? We do see that their therapeutic alliance is still very strong with these devices. When you are having regular follow-ups still, maybe they're just spaced apart more than they would be, and maybe they're over the telephone, maybe they are video calls, maybe they're in virtual worlds. We see that the therapeutic alliance is still comparable to attending in-person appointments. But the research that's looking at that is already 10 years old, and perhaps people now post-COVID are much more used to using telehealth, using video software. It's something definitely worth looking into again, because there's been a bit of a shift in the social cosmos as to whether people enjoy using video calls or not. When it was novel, perhaps people liked it more. Maybe people want that face-to-face. So it's something definitely to explore. So key takeaway I want to get across here is that it isn't a replacement for what we're doing already with rural healthcare. It's another option. It's something that people can try and use, and perhaps it's going to be great for accessing 10% of the population that previously were not getting the access to healthcare that they needed. It's comparable, if not more effective, than current treatment options or interventions. And we're pretty sure that it's feasible and scalable, and that's what we need to look into in more detail. It's very important to understand perhaps what we're going to be doing in the future, but what I want you guys to think about is what infrastructure gaps exist. Where do you see this being implemented? Where do you think this could be piloted? Where do you think it would fit most nicely within your area of expertise? It'd be really great if you have any ideas around this. If you want to chat through it in any detail, drop me an email. We can have a call. My details are obviously emails at the bottom there. But yes, so that is everything from me. There's the reference list if you want to have a little look at it. I'm sure these slides are being shared in some capacity. But yes, I'll now remove my hands from the control. Thank you for your time.
Right. I think I can take over now.
Yes.
Let's see where we are. Yep. All right. So thank you, Sam, for your presentation. There is some overlap, but I'll just quickly, scoop through the things that you explained very well. And yeah, as Dennis said, my name is Sil Slatman. I'm based in the Netherlands, and I'll be talking about my PhD research, which I basically finished. And my PhD was on the added value of VR in physiotherapy for people with chronic low back pain. And yeah, I've got a background in physiotherapy and psychology, and I'm mainly interested in chronic pain, but during my PhD, I learned to love VR as well. And currently I'm actually looking to continue working on VR, not for people with chronic pain, but more for healthcare professionals as well. But today I'll be talking about the following topics. I'll just start with a quick definition of XR, even though Sam already provided a nice overview of extended reality in general and VR, AR, and mixed reality. I'll also quickly talk you through the history of VR and the technological developments that have been happening in VR and that are currently happening still in hardware development. I'll give a brief overview of pain as well, but I figured since this is a pain community, I think I don't need to go into much detail on, for example, pain science education. So it will be quite a brief overview of pain, and I will just dive deep into VR for acute pain, VR for chronic pain, and I'll share some of my own research as well. So first of all, I see the slide shifts a little bit, but of course, extended reality is the broader term used to classify augmented reality, mixed reality, and virtual reality, as Sam already mentioned. And yeah, you can see it as a spectrum, and also as Sam mentioned, there's quite some arguments, still some debate in scientific literature and among researchers to see what VR actually is, and there are people with different opinions on what VR exactly is and whether it should always be immersive, or if non-immersive VR could also be named VR. So we're still in quite of the early stages of VR research, of course. So we're still figuring out what terms to use, but I think we already got quite a nice overview of the different options on VR. But it might be nice to share this little timeline of VR hardware development through the past 100 years, basically, because when we're talking about the history of VR, you can go back even further in time, of course, and for example, talk about the first 3D paintings or paintings that had some sort of level of depth where you felt like you were in some sort of immersive experience. But when we're talking about the history of VR hardware, we usually start around 100 years ago with the Link Trainer, which was basically a flight simulator that already responded to your action. So if you would steer left, the entire plane and your field would shift left as well, and the same for flying to the right. So it was used for pilots to learn how to fly a plane. So actually the first VR hardware was used to train professionals instead of training patients, for example. And of course, we had the technological developments through the years, and it's the same, of course, with the first computers and the first smartphones. The chips just got better and faster, and we needed that to eventually develop, of course, the VR headsets that we know nowadays. Because still around 2000, we had the first VR headsets that resembled the headsets we use today to some extent, but they were still quite, of course, very old school. They had the big cables to get electricity, and they were still very slow, sometimes not even use color vision, but just black and white. But since 2016, the first commercially available headsets came on the market that were standalone, so they didn't need a computer to run their to basically to run the program they were running on, but they can just do all the calculations themselves. And through the past few years, the technological advancement just got better and better. And just with our phones, we got more chips and better chips in smaller phones, and also the prices dropped. So the developments are going very quickly, and the graphics are getting better, and the headsets are getting quicker and quicker. So it's going nicely. So it would be interesting to see where we stand in 10 years again, to see whether this technological advancements keep going, or whether we're plateaued after a while. But I know that Pico, that's one of the big VR headsets companies, it has been quiet for a while. For a few years, they didn't present any new headsets, but they'll be presenting new hardware soon. So it would be quite interesting to see what's going on there. And of course, also Apple with their Vision Pro, they also stepped into the game. So it's nice to see what's going on there, and all the new functionalities like eye tracking and things we can use in VR now. So it would be interesting to see where we're going. But when we're talking about VR and pain, I'll give an overview of pain first, but I'll skip through it quite quickly, because I think most people that work, for example, physiotherapists that work with patients with pain, or people with chronic pain, they know that there's this big gap between our former understanding of pain, or at least our understanding of acute pain, of course, where there seemed to be quite a clear distinction between body and mind, and that pain would be like a very physical sensation where a nerve would like pull on the brain and say like, oops, there's pain here, maybe you should remove your hand from the fire, and then the pain goes away again. There's a nice publication that was published, I think 1 or 2 years ago, in Pain Reports, about like it's a 5,000 year long history of pain throughout the centuries. And it gives a very nice overview of people thinking about pain through the years. And it ends with our current understanding, of course, of pain, which is that pain is a very complex problem, especially chronic pain. There's usually a lot of factors involved, and we talk about the biopsychosocial model, of course. And of course, we also have things like phantom limb pain. So it's much more complex than the more simplistic or reductionistic view of pain, where it's like just a nerve signaling pain or not. So I think that's important to keep in mind when we're talking about VR for pain as well. And I think it's also nice always to show this little figure. It's from a quite well-known article, I think, where they did imaging on asymptomatic individuals. So no one in this study had any complaints, and still their imaging showed quite a lot of interesting results, where a lot of people had, for example, disc bulging, and you see it increasing over age. But I think it's always nice to show this, especially to patients that really like to see imaging, to see what's going wrong, to show that also in asymptomatic people without complaints, there's also a lot of things going wrong. So there should be another explanation for the pain besides just their imaging. And finally, regarding pain, of course, it's quite a big problem. It's somewhat of an hidden epidemic, as about 1 in 5 adults suffers from chronic pain in industrialized countries. And some of the diseases with the largest global burden of disease are pain conditions like low back pain, neck pain. Sometimes they differ a little bit in the list, but they're always in the top 10. There are always some pain syndromes or pain complaints. So it's a big problem. So this is like a short introduction of VR, short introduction of pain, and then moving on to VR for acute pain or VR for pain in general. Because when we're talking about VR and pain or XR and pain, we should go back to around the year 2000 when Snowball was developed, because this basically the first VR intervention for people with pain, and it was developed for children and young adults that were burn victims. They had quite severe burns, and they had bandages that needed to be replaced daily. So there was quite a painful procedure because their bandages would stick to their skin, and their therapist had to remove the bandage, which was quite a painful procedure, and replace it every day to make sure it's a clean bandage. And usually the patients were given opioids or very strong painkillers to cope with this painful procedure, of course. And around the year 2000, Hunter Hoffman, who was an American researcher, thought that one of the very old school, of course, VR headsets could be used to distract these patients and make sure that they didn't use or they didn't have to take any medication or pain medication, because of course this pain medication came with a lot of side effects and negative adverse events. And so they developed Snowworld, which of course it's the opposite of burn victim. It was in a snowy world where patient that played the game had to shoot with snowballs or throw snowballs to penguins and ice bears and all kinds of animals. But it looked very, very old school, as you can see in this video. It's it doesn't resemble what VR looks like nowadays at all. So because nowadays, of course, the graphics are much better, but they used this and they showed it. Comparable results to using pain medication, but of course then without all the side effects, and you can just put on the headset and play this. And they thought, okay, this is quite interesting to see that VR could be used for people with acute pain, and then later on they thought it might also be interesting for people with chronic pain. And I've got a summary of the literature here. This is a recent systematic review with meta-analysis that combined a lot of VR research, and they basically state that VR is effective for acute pain, which I completely underscore as well, because VR, of course, is a very strong distractive tool, and I think that's the main working mechanism when you use it for people with acute pain, because you get you're totally immersed in this other world and you completely forget about the painful procedure or anxiety-inducing procedure that you have to go through. But this review also states that VR is always effective for people with chronic pain, and I'm a bit more skeptical in that regard, but I'll come to it later on a little bit. But I agree that VR for acute pain, I think it's a no-brainer, and I think it's shown its effectiveness for in a lot of studies. So I think we can safely assume that VR could be used for people with acute pain. But I think for VR and chronic pain, it's a bit more complicated, and I'll discuss why. But first, I'll give an overview of some different interventions or VR modalities you can use in VR. Sam already showed the Relief XR intervention, which is it's very nice combination of pain education, relaxation modules, distraction modules, but VR can also be used for other working mechanisms or for other clinical goals. And one reason we use VR is for exercise therapy, and use, of course, the gamification part and the motivational part of VR to make sure people do their exercises, or for example their homework exercises. And one example is Beat Saber, which is just a very nice fun game to make sure people exercise. And yeah. Yeah, it just, as you can see, it's just a fun game. We also still play it here at our university sometimes. We still like to play it as well. And our patients, if they can handle it, they also really like it. So I think exercise therapy is another reason you could use VR to help your patients. But also, of course, education, pain educations. We also did. We've got a specific module for pain science education as well that we use in our research. And for example, in Australia, there's also a very well-known VR application for pain educations. So it's a very nice way to teach patients, but it could also be used to teach healthcare providers, of course, because the physiotherapy students of our physiotherapy bachelor and master education in the Netherlands, they also get some sort of anatomy VR program where they learn how to, for example, where a muscle starts, where it ends. They teach it in VR as well, so they get some extra education in VR. So it can be used for patients, but it can also be used to educate the healthcare providers. You can also use VR for cognitive training, of course, for example, to improve concentration, to improve memory, which could be a complaint, of course, for people with especially chronic pain problems. Well, we already saw the relaxation part. This is quite famous one, swimming with dolphins under the sea. I think that's a nice benefit of VR as well, that you, in one headset, you can use software where you, for example, you're in space, or you can be on a nice sunny island, or you can be doing a hike through the mountains, and it's all in one VR application. And this one is under the water, swimming with dolphins. It's also quite a nice, fun one for patients to to distract them and to relax if possible. Yeah, and finally, VR can be used to embody a different avatar, or to embody a different character. For example, in patients with chronic pain that have a distorted body image, you can use VR, for example, to give them some sort of happy story about their life, or a happy story in their body. And that's something that Daniel Harvey, for example, did. He's an Australian VR and pain researcher, where people with chronic low back pain, for example, embodied the Hulk, and they went to the gym and they were the Hulk, and they can use all the weights, and it gave them some sort of positive feeling about their body again. So it's something you can use it for as well. And when we're talking about research or literature about VR and chronic pain, there are some conflicting reports, because the review I recently showed, or I just showed, said that VR is effective for people with chronic pain in general. This is another one that's also a systematic review and meta-analysis. It was conducted in 2022, so it's a bit older, but still not that old, which it basically states or concludes that there's not sufficient evidence yet to state that VR is effective for chronic pain, and I tend to agree with this a bit more, because I think there are a few limitations in VR for chronic pain research that just makes it a bit harder to already really get a good overview of the existing evidence so far. And I think, first of all, the method of action is almost never understood, because I think in VR for acute pain, distraction usually is the working mechanism, the method of action. But for chronic pain, there could be a lot of different mechanisms, of course. We're talking about, for example, the placebo effect is an effect that's very hard to rule out. There's always distraction, also for people with chronic pain, of course, when you put on a VR headset, it's always distracting. And also a lot of these VR meta-analyses, they all combine exercise VR, relaxation VR, education VR. They all combine it into one big meta-analysis, and then they state, okay, VR is effective, but they don't really do subgroup analyses where they, for example, think that, okay, a one-session education VR should not be compared to a 12-week exercise VR. So I think there's sometimes too much heterogeneity in these VR modules to really group them well so far. And as Sam already mentioned as well, there's a lack of agreement on VR definitions, immersion definitions, extended reality definitions. So I think we need some work there before we can really conduct nice meta-analyses. And still there are quite some studies with suboptimal quality, or for example, they don't have a control condition, or they don't really have any long-term follow-up measurement. So it's quite hard to see what the durable effects are. So I think there are some limitations in research so far to state whether VR is definitely effective or not for people with chronic pain. But when we're going to, so this was a lot of theory. I'll go to the practical side of it now for a bit more. Because I'm conducting, of course, research in physiotherapy, and we also work together with a lot of physiotherapists. And this is based off one of a colleague of mine that was, she had quite severe shoulder instability, quite severe shoulder problems. And my colleague thought it would be nice to see whether VR would be effective for her. So she, on the video on the left, I'll show in a bit, you can see that she's just raising her arm, and it's quite a painful movement pattern, as you'll see. Oh, wait, let me try again, sorry. So this is basically movement without any VR. Next, she'll try quite a basic VR module where she has to pick some apples from a tree above her. And you'll see that the movement pattern is completely different. And this was maybe a few minutes later. Yeah, and I think it's always fascinating or fun to show these videos because it shows how quickly VR could exert its input even on people that have had shoulder complaints for years, because she's been having complaints for years. She's had some big surgeries. You can still see the scar on the shoulder. So these really aren't acute patients. These really are chronic shoulder patients. But I think the problem is we are still not really sure what's going on here now. So I think I would love to explain what's happening in her head right now or why she's doing this right now, but we're still not sure whether it's just a distraction or if it's the external focus or whether it's the predictive coding that's being disturbed. So we've got multiple possible working mechanisms or multiple hypotheses why this is working. But yeah, the honest answer is we're still not sure why it works. And we also interviewed her, but she also couldn't really state what was going on. But it shows that it helps, and it also can help to just make a video of the patient and show it to her afterwards and discuss what's going on. So you can also use it, of course, for a starter for example, pain education. And some studies that I did that would be interesting to show you as well are to see whether VR is being used in clinical practice already. And I also found a study among English therapists, and I'll show you in a bit. But what we found, we surveyed physiotherapists that were working in clinical care, whether they used VR for their chronic pain patients. And the survey showed that there's only it's still in its infancy. It's a limited amount of therapists that use it now, because there are some barriers that Sam also mentioned, like the cost, but also they weren't sure about the effectiveness, for example. But our study showed that approximately 7% of therapists used VR or had used VR, and it actually corresponds quite well with a study from the UK, even though it was among pediatric physiotherapists. But that also showed that in approximately 7% of respondents, VR was used to help their patients. So I think we can safely say that in both the Netherlands and the UK, VR is still in its infancy, of course. And we also did another interesting study that I wanted to show today among physiotherapists that either still use VR or had used VR but stopped using it. So we've got some more maybe positive people and some more negative physiotherapists to see what their perceptions and attitudes were for VR use for chronic low back pain patients. So we interviewed 11 of them, and a few themes came up that somewhat corresponded with Sam's part as well. But first of all, VR was perceived as non-threatening to the physiotherapist's role. Because sometimes when I talk to VR naive physiotherapists that don't really know much about VR, they're a bit afraid that VR might take over their role or take over some of their work. But the physiotherapists that had actually some experience in VR, they were quite certain that they still had, of course, way more to offer than a VR headset could offer, and I completely agree. So I think VR is a very nice extension, or as the title of the study is called, it's a very nice tool for the toolbox, but it's an addition and not a substitution of care. And secondly, VR was really valued because it had distinctive qualities. For example, the immersion factor or the sense of presence where you're completely immersed in a different world that was usually used to help patients. But the third theme was that there were some contrasting attitudes among both patients and physiotherapists, and not everyone was too happy with VR, or some patients also just didn't really like it. So I don't think it's a tool that's suitable for every patient, and also not a tool that's suitable for every physiotherapist. So yeah, you should have some sort of connection with it. And that's also basically the fourth theme, which states that physios need specific skills and some positive attitude, also because VR, of course, it's still in its infancy, and sometimes there's a bug or a lag or something going wrong with either the software or the hardware, and it helps to have some digital skills to be able to cope with it. So there's also still quite a lot going on there. Where the physiotherapist also stated that they just needed a bit more education and some more knowledge on VR before they can really implement it well and effectively in clinical care. Yeah, I think that's it. So this is my final slide. Are there any questions also for now? But if you've got any questions later on, feel free to just send me an email or hit me up for an online chat. Hey, Dennis.
Thank you, Sil. And thank you, Sam. Two very, very interesting presentations. And hopefully that's given you an insight into the history and current and future thinking around the application of XR for pain management specifically, but also in rehabilitation in general. Now, we do have time for questions. I can see some questions in the chat. And also, if you want to raise your hand, although I have to admit my sight of hands is going to be limited. So some of the questions, Sam, there was a question here for you about the Eva Park setting, and it's come from Vicky. It's really just asking, do you know of any research which has compared the health benefits of nature in real reality, as it's called, with the effects of bringing nature in through virtual reality?
Yeah, that's a nice question, and the answer is yes, but not in the Eva Park study. So the Eva Park setting was initially around benefits for stroke, or at least when I say not in the Eva Park, I don't know of anything in the Eva Park setting. But there's a chap called, I know his name's Sam, because it's the same as me. I think it's Hughes. I think it's Dr. Sam Hughes, who's looked at some comparative between VR nature versus just looking at a picture, a 2D picture of, I think it was like a setting in waterfalls, and it was definitely in favor of the VR showed reduced pain levels. So it's chronic pain, using nature as its calming influence to see whether it was better to be in the VR setting or just a 2D picture, and the VR was shown to be more effective. I think that there is still ongoing research with that. I think Dr. Hughes is still looking into that at the moment, specifically with chronic back pain.
Yeah, that's in University of Exeter, I think,
Yeah,
where,
that sounds
where
familiar.
Sam's
Yeah.
based. I have come across some work in Germany where they're looking at this, and they refer to it as nature washing. And the idea of nature and health benefits is pretty well established, and the theory of bringing nature to people, often when they can't actually access it themselves for whatever reason, is a good one, and the evidence needs to follow. But yeah, strong possibilities. Cormac, I see your hand up.
Thanks, Dennis. Can you guys hear me?
Yeah.
Perfect. Yeah, just really enjoyed the two presentations, and the question I have is for both speakers. One is, have either of you guys used VR in your own sort of clinical practice as part of routine care, even with just one or two patients, or do you use it with plenty? And what was your experience of doing that? That's kind of number one. And the second one is, it looks like what we've got 7% of people in both countries using VR for health, not necessarily in pain, but for health. Do you guys ever see a time when actually that's going to be flipped and it's going to be more like 70%? And if you do foresee such a time, when do you think that might occur? Is it in 10 years' time, or is it in 100 years' time?
Sam, do you want to start, or should I?
Yeah, sure. No, yeah, I'll say something on that. So with regards to using it in clinic, I've used it with two patients, but with the caveat of I've had to give them my own device because I work for the NHS, and so it's a case of outside of the NHS setting. But first with stroke patient who has found it very useful, but it's more about the motivation and the gamification of being able to engage with upper limb rehab. Just found it much more engaging. Initially, technological barrier was quite difficult to overcome, but actually found it much easier to use once it was set up than they were expecting. So I think there's often this perceived barrier that once you're like, oh, I just click here and here, it's a bit like the first time you use any new piece of technology. It's like, oh, actually, it's really, really easy. It's 3 buttons. Fine. The other user was a polytrauma who is finding it continually useful, but it was their idea to use it as well. So it's something that they've kind of found out themselves and just happened to be a good person to speak to about it. Yeah, and that second question about adopting VR, really, I think there's so many different factors around how it's going to be adopted. I think that my suspicion is in the next 10 years is probably the window where we're going to see it becomes a much more everyday device, because that's how the technology is progressing. In the same way that 20 years ago, the smartphone didn't exist. By 2016, 2018, everybody has a smartphone. And I think it's that elementary version of technology doesn't get great uptake. There's not a lot of first-time users of these devices because they're expensive. But if you look at the funding going into it through Meta, the Facebook company, there's loads and loads of money being put into improving the systems that exist. And the more integrated they become with everyday use, the more it's going to be useful to use in healthcare settings as well.
Cool. Thanks for that, Sam.
Yeah, and I don't work in clinical practice. So I only work as a researcher now. So I don't have any experience providing VR to my patients. But of course, I work with a lot of physiotherapists that still work in practice and use it. For example, also Beate Diaco, she's a colleague of mine. She's doing her PhD in VR for shoulder rehab in physiotherapy. So we work quite closely on things. And she still works in practice, and she used it for almost all of her patients. And she's had some really spectacular results and also published some case reports. She's doing her PhD with Jeremy Lewis, so the shoulder guru, I think. So she really has some very enthusiastic patients, but she also has, of course, patients where it doesn't do much. So she really says it depends on the patients, but you can't really decide beforehand on for who it works and for who it doesn't work. So unfortunately, I'm not able to try it in practice myself. But yeah, we see it. I see it happening quite a lot. Maybe I'm somewhat biased because I know a lot of physiotherapists, of course, that are interested in VR, and they might be a bit on like the early adapters instead of the late majority, innovating a little bit less. But I feel like it's getting there more and more, and it's getting normal quite in some regions of our healthcare system. For example, in like secondary and tertiary care, I don't think there's any hospital in the Netherlands that doesn't have a VR headset, especially for example, acute pain, procedural pain, anxiety. I think most hospitals, yeah, they almost treat it as usual care, where they just provide VR headsets. So I think it's quite common already in secondary care. And regarding adoption or broader implementation, I definitely think that the number will grow, but I'm not sure if we'll ever reach 70%. And I think, of course, with technological advancements, I think in 10 years we didn't have AI, of course, 10 years ago, and nowadays AI is all around us. So maybe there will be, I don't know, lenses or I don't know, smart watches with extreme functions. I've got no idea, but I'm quite hesitant to do projections for the coming 10 years. But of course, I know a lot of people that they're convinced that in a few years everyone will have a VR headset at home. So yeah, we'll see. What's your opinion?
Oh, first, thanks, Sil. That again, a good explanation. It's really difficult to say. I think, it's so hard to predict the future with respect to technology. It changes so unbelievably quickly, and the AI is the example. Who would have thought even 3 years ago there'd be a tool that everyone could access for free, where you could just ask it a question on anything and get an expert opinion with the odd bizarre opinion thrown in. So it is extremely difficult to predict. However, I do think that there will come a time where the walking into a clinic physically and speaking to someone it becomes almost like quaint, something that like a minority of people do, rather than like writing letters. You know, there's still some people who write letters, but those people are in a minor, and it's a lovely thing to do. But it's just, there's quicker, faster, more efficient ways of doing it. And if you think about people at work, people at distance, etc., when the technology gets really good, I think virtual clinics and virtual rehab will become the dominant thing. But I personally, I think I will have retired, and that's at least 25 years away.
Yeah.
There's some I've heard Chris Eccleston, you'll know Chris, based down in Bath. Chris presents a very persuasive argument that in pain management, the scale of the problem is so high. There's so many people living with chronic pain and requiring support, that it far outweighs the number of health professionals who are available and equipped to help. And with the numbers of people with pain increasing, number of healthcare professionals not keeping up, Chris's argument is that really digital is the way of supplying support at that scale that's necessary, and face-to-face interactions will become the minority, even perhaps a luxury, and XR has a role to play within that. And it's interesting in terms of clinical practice where it's implemented. Chris, I know, has been doing some work with Nick Perry's and his team, his clinical team in Devon and Torbay in the south of the country, where they have integrated VR and XR into their pain pathway. It's part of their standard care. I think they're one of the leaders in it. And I'll put in the chat, I've just put in a link to the XR Health Alliance, which is a group who have done a mapping exercise and an audit of XR in clinical practice and research and development across the country, which includes a lot about chronic pain. So it's worth having a look there to see. I think it's much more widespread standard use in mainland Europe, I think, Cormac. But it's certainly appearing very much in the UK. So,
cheers.
Okay.
Thanks very much, guys.
I think we have one more question. Vicky, you had asked, is there a chance to use XR as a hybrid approach, some face-to-face and some virtual? And you're thinking of escape pain, which used vicarious learning and patients learning together. Could this be possible with XR? And I think we do see that happening. And one of the applications I think Sil referred to and been used over in Australia, the Reality Health Package, which augments face-to-face pain science education with a VR package, which patients can use alongside their physio to enhance the interaction. We looked at that here in Teesside, and colleagues over in UCD and UCC in the Republic are looking into that as well. So yes, it is in practice, and yes, it is possible. I'm conscious of time. We do want to keep in time. So we're going to finish there. And a big thanks to Sil and Sam for the presentations and for taking the questions. And the next bit is really a reminder about filling in the online form. Paul, you had highlighted there might be a problem with filling it in, although others seem to manage it. Please do persist. And that is to transfer from NENC across to us in Teesside and the Arc to continue the pain community of practice. We have a QR code. If you could scan that and please provide some input into the post-seminar survey, and I'll give you a couple of minutes or a little bit of time to do that. That would be very much appreciated. As I say, we will have out with this pain community of practice series, but there's another series of webinars which are looking at XR in rehabilitation in different strands, and I can provide the timetable for that, and I do invite you to join us in it. We have our XR for Rehab conference in June 25th and June 26th in Cork. And registration is open for that. Everybody is very welcome. You'll hear some more of the ideas which were discussed today and give you a chance to meet Sil and Sam in person. So if we can then go, there's a specific evaluation for this, which you can feedback through the Teams poll. Which you can see. And okay. So yeah, thank you for coming along. The recordings and presentations will be on the future platform. We have our next meeting on the 3rd of June, 30th of September, 9th of December. The details will follow, and please do switch over on the consent form. So without further ado, thank you very much, and we'll see you all at the next session. Thank you. Bye all.